Chapter 24, Nonsurgical Periodontal Therapy. So there are many non-surgical steps to eliminate inflammation in the periodontium of the patient with periodontal disease as an attempt to restore the periodontium back to health. So back to health, first of all, let me explain that. When you are doing non-surgical periodontal therapy on a periodontal patient, back to health, you are not trying to restore the periodontium back to its original state, because remember, alveolar bone loss does not come back. So you are trying to restore the periodontium to health, so absence of inflammation, absence of disease. A combination of professional care and patient self-care is required. So there's something called the gold standard. The gold standard is like our expectation. What do we hope to achieve? Why are we doing non-surgical periodontal therapy? So the gold standard for non-surgical periodontal therapy is the cornerstone of the periodontal therapy. It's the first recommended approach to control periodontal infections. So when we are trying to control periodontal infection, you're going to the attachments such as the periodontal ligament and the alveolar bone. Our first approach is to stop the disease process. So kind of think of it like a house. If you have a house that's on fire and you've got your foundation and then you've got your house and it's all burning down, the first thing you want to do is put out the fire. You're not going to stand there and try to rebuild a new house while the fire is still going on. So first thing you have to do is put out the fire. Then you're going to go back and you're going to assess the damage that was left over after you've put out the fire. And you're going to make decisions on what needs to be done then to repair the damage that was a result of the fire. So same thing goes on with periodontitis. So you've got damage to the periodontium, to the periodontal ligament, the alveolar bone, the fibers. So first thing you want to do though is stop the damage or the destruction, or halt the damage, the destruction. So you're going to put out the fire being the active bacteria that's destroying the underlying structures. Then once you've done that, then you can assess the damage and determine what, if anything, do you need to do to repair the foundation. So you're going to hear alternate terminology. Other names that it's called is initial periodontal therapy or initial therapy. So the names initial mean that it's the first phase or the first step in treating the disease process. You'll hear it mainly caused phase 1 treatment or soft tissue management. That includes the patient's self-care, education, the periodontal instrumentation, and the use of any chemical agents. So patient self-care is extremely important. You can do all your best periodontal instrumentation. You can scale till all the calculus is removed and everything is just nice and smooth and clean. But if the patient goes home and they don't do anything at home, it's not going to do any good. So one of the first things you want to do is you want to educate the patient on how to take care of things. So what are the objectives? The objectives to non-surgical are to eliminate living bacteria in the microbial biofilm. So you want to also eliminate any calcified biofilm. In other words, you're going to remove plaque and calculus. And then you want to return the periodontium to a healthy state for continued maintenance by patient and professionals. Notice the healthy state for continued maintenance. We are not fixing the problem and bringing it back to its original state. We are trying to maintain it at its new state. The basic philosophy to plan individualized treatment that provides for control, elimination, or minimization of the primary etiologic factors, the local risk factors, and systemic factors. So you want to individualize the treatment for starters. Not every patient is going to be the same. We all know that now. Not every response to treatment is going to be the same. Even the same patient may not respond to the treatment the same on both sides of their mouth, or they may not respond to the treatment the same way the second time around. Local risk factors, we want to eliminate or manage as many of the local risk factors as we can. Sometimes we can't eliminate them. If the patient wears a partial denture, a removable partial denture, and there's occlusal trauma or occlusal issues with it, so there's only so much we can do to give them back function and not have compromised periodontium. Systemic factors, same thing with systemic factors. We can try and help them manage their diabetes and help them manage their excessive hormones from puberty or menopause, but we can't totally control that. So the general principles for controlling periodontal infection is daily patient removal of supragingival plaque biofilm is important. How are we going to do that? We're going to use a toothbrush, a floss, a water flosser. So a toothbrush of some kind and an interdental cleaning of some kind. Think of the tooth as a cube like we did in dental anatomy. So you've got your mesial, your distal, your buccal, and your lingual. You've got to clean all four sides of the cube. Generally, your toothbrush is going to clean your buccal and your lingual, and then some kind of interdental aid, whether it's floss, a proxy brush, a toothpick, but something has got to clean the mesial and the distal. We can't just clean two sides and leave the other two sides dirty. We have to clean all four sides. The routine periodontal instrumentation to keep subgingival microbial biofilm under control, that's going to be your scaling of root planing, and then your perio maintenance. So routine periodontal instrumentation. Patients have got to understand, and it's your job to help them understand, when they are finished with scaling and root planing and they come in for their reeval, that you have not cured their disease. You have managed it. You have made it controllable by them, but you have not eliminated it. They are always at a risk, once they've had periodontitis, of recurrence. And office visits are recommended every 3 months. You will be hit all the time with the question of, my insurance only covers 2 cleanings a year. Is it really necessary for me to come in every 3 months? Yes, is the answer. Bacteria and plaque build up and continue to mature. 3 months, you're cutting them off before it gets to be too mature. Remember, one of the things we want to do is we want to keep biofilm at an immature state. We don't want mature biofilm. Mature biofilm contains some really powerful bacteria. Every 3 months is one way to keep that biofilm from becoming too mature. I would always approach the patient with the idea that obviously they can do what they want, but if they don't come every 3 months, they're likely to have a recurrence of disease and have to repeat this whole process again. Patients usually don't want to do that. So 3 factors that influence non-surgical periodontal therapy outcomes are the patient compliance. Is your patient doing everything they can, brushing, flossing, using all those oral hygiene aids that you had asked them to use? Their lifestyle or systemic factors. Are they trying to manage their lifestyle or systemic factors? Lifestyle being, do they smoke? Do they eat a lot of sweets? Do they do a lot of things that they shouldn't be doing, or abusing alcohol? And then systemic factors. Are they managing their diabetes? Are they managing any kind of autoimmune diseases they might have? And that kind of blends in with disease factors. Goals of non-surgical periodontal therapy. The 4 goals are to minimize the bacterial challenge to the patient. So we want to work with the patient to try and minimize their challenge or make it easier for them to keep their teeth clean and healthy. To eliminate or control local contributing factors, so things such as controlling calculus, making sure they don't have any overhang restorations, or if they have some Poorly contoured crown margins, they are using the correct cleaning aids to maintain those areas. To minimize the impact of systemic factors, so minimizing your host response, making sure that whatever systemic factors you may have, that they are controlling them. And to stabilize the attachment level, so we don't want to see clinical attachment loss increasing over time. Types of procedures, there are 7 types of procedures. We have patient education. We're going to teach the patient how to take care of their teeth and gums. Instrumentation, so we're going to scale them. Use of antimicrobial agents, so perhaps you're going to put them on Listerine or something similar at home. Use of adjunctive, supra, and subgingival irrigation, so they can use a water pick or a hydrofloss or water flosser. Correction of local contributing factors, so one of those things, as we talked about, would be making sure that removing the calculus as a contributing factor, but also making sure they don't have any poor restoration margins. And if they do, and they can't change out the restoration, that they are able to find a cleaning aid that can get in there and keep the area clean. Interprofessional collaboration for correction of systemic risk factors, working with their medical doctor. If they take a calcium channel blocker and they're getting gingival overgrowth, making plaque removal extremely difficult, perhaps a conference or a call to their medical doctor to explain some of these things to help them either take them off the medication or make whatever necessary adjustments need to be made. And modulation of host defenses. Typical treatment plan for dental biofilm-induced gingivitis is to customize the self-care instructions. Every patient is different, and what works for one patient may not work for another, or it may not be the most effective thing for the other patient. Patient attitudes, patient compliance, all that has to factor into customizing their instructions. Periodontal instrumentation, so having regular dental cleanings. Eliminate local factors and re-evaluate the periodontal response. So on a typical treatment plan, we have the 4 stages for periodontitis. We have 3 grades, stage 1, 2, 3, and 4, grade A, B, and C. Typically, if you look at the first 5 or all 5 of those things, they're pretty close to the same. You're going to customize the self-care instructions, periodontal instrumentation, eliminate local factors, correct the systemic risk factors, and re-evaluating periodontal response. The only difference is that between the stage 1 and 2 and the stage 3 and 4 is that you are going to reevaluate the periodontal response for the possibility of surgical needs. So basically, you may be referring them to a periodontist to see if they need to have any kind of surgical correction. Patients that are in stage 3 or 4 typically have more bone loss, furcation involvement, some mobility on teeth, things like that. So if reevaluating their response, is surgery going to help them? Maybe something that a periodontist can help you with. Mechanical non-surgical therapy. So biofilm. Physical removal is the most effective mechanism of control. So we want to be able to brush and floss. And then calculus is a critical component in the treatment plan. You've got to remember that calculus in itself is not, does not cause periodontitis. Calculus contributes or is a risk factor for, but it does not cause periodontitis. It harbors living bacterial biofilms and it holds them against the tissue, which is how it is a high risk factor or a big contributing factor, but calculus by itself does not cause periodontitis. We want to preserve cementum. So this is the paramount importance for quality of healing, is preserve the cementum. It can influence activities of periodontal cells. Periodontal reattachment lies on the presence of cementum after root instrumentation, and it provides tooth attachment and maintenance of occlusal relationships between jaws. So we have a lot of archaic thoughts on cementum. Archaic thoughts went back to when I was in dental hygiene school. We mistakenly believed that endotoxins penetrated cementum. They do not. So remember, on your gram-negative bacteria, the cell wall or the outer envelope contained endotoxins or lipopolysaccharides, abbreviated LPS, that were released when an immune cell attacked it, and it released these endotoxins. And we used to believe these endotoxins then actually got into the cementum, the structure of the cementum, and that we had to scale the heck out of the cementum to try and get what we called a smooth surface. What we found is that we were removing so much cementum with our scaling process that we were inhibiting the ability for healing. Cementum plays an important role in the healing, and so we were actually, by removing it, we were removing healthy cementum as well as necrotic cementum. We no longer believe that's the case. We try to conserve the cementum as much as possible so that we can improve our healing. So the desired endpoint of instrumentation during non-surgical therapy. So usually we get the formation of a long junctional epithelium. And these are two pictures here. This one on the left shows you what the junctional epithelium looks like. So here you've got your tooth, you've got calculus here. This is your outer epithelium. And so as inflammation resolves, the epithelial cells readapt to the root surface. So this big, tall inflammation, this was probably your gingival margin was up here, making the pocket deeper. Now as inflammation resolves, notice that the gingival margin will come down lower. And there's your junctional epithelium, and you should have a very shallow probing depth right there because this looks pretty healthy. If you look at this right here, this picture right here, you have some alveolar bone loss down here. Remember, you are not going to gain any alveolar bone, any cementum, or any periodontal ligaments. So we still have the loss of the periodontal ligaments and the alveolar bone down here. But over here, we have the junctional epithelium reattached itself to the root and reattached itself slightly onto the enamel surface, which is where it should be. But because the bone and the periodontal ligaments were lost early on, this junctional epithelium right here now is very long compared to this junctional epithelium here. And so your gingival fibers were in this space right here. And notice you've had some destruction of these fibers. And so your junctional epithelium filled in the space. If you probed this, you would get a shallow probing depth. This is an okay situation. It's not ideal, it's not perfect, but it's okay. This is just another picture. If you look at this picture here, you had your pocket epithelium right here. And then you have your alveolar crest where the bone has been eaten away, your periodontal ligaments that have been slightly destroyed. So you are going from the gingival margin, you're probing down, and you're at about the 5 millimeter mark for the base of your pocket. On this side, if you notice, your junctional epithelium reattached itself. And so it's a longer junctional epithelium. It goes from about 5 millimeters up, which is where you were over on this side. It's reattached itself up to the 2 millimeter mark. So now if you were to stick your probe in, you have a nice shallow pocket. This is just another picture showing some reattachment. Dentinal hypersensitivity is a short, sharp, painful reaction that occurs when areas of exposed dentin are subjected to mechanical, thermal, or chemical stimuli. So your mechanical stimuli might include toothbrushing. Your thermal stimuli might be eating cold foods or sweet foods. And your chemical stimuli might be acidic foods. But it can even occur when you're outside breathing cold air. This is a picture of your tooth right here, and here's your dentin. Your dentinal tubules are little round tubes that run perpendicular to the long axis of the tooth. Remember, the long axis of the tooth is a horizontal line, a vertical line. Your dentinal tubules run horizontally. And this picture right here is what they look like. So within each tubule is an odontoblastic process, which is a direct extension of a cell in pulp called odontoblasts. One function of cementum is to keep dentin covered to protect it from external stimuli. So it acts as a barrier. It's like the jacket. The dentinal hypersensitivity, when dentin loses its protective cemental cover, the dentinal tubules are then exposed to the oral environment, which causes the intense pain. Associated with gingival recession of the gingival margin, approximately half the patients experience this after scaling and root planing. One thing you can do in clinic is you can give your patients some Sensodyne and explain to them, take a few minutes to explain to them that their teeth are probably going to become sensitive to cold or sweet, or even cold air or toothbrushing now that they've had this procedure done. You're going to give them this anti or sensitivity toothpaste so that it will help seal off those little nerve endings that are now exposed. Patients who have scaling and root planing, they have like kind of a double protective layer on their root surfaces. So they've got the cementum that covers the root that you're going to kind of disrupt when you're scaling. But they've also had calculus and plaque that have been forming an insulator from the outside environment. So you've taken all the calculus and plaque off and some of the cementum off when you do your scaling and root planing. So now those poor little babies are all exposed and extremely sensitive. When your patient goes home and the anesthetic wears off and they take a big sip of something cold and you don't warn them about sensitivity, they're going to be very upset. And they're going to be a little bit nervous or worried about why do their teeth hurt so badly. They didn't hurt when they went to the dentist. They come home from the dentist, their teeth hurt. So that's why it's good to explain this ahead of time and head off the problem. Your teeth may be sensitive. That's okay. It is not a problem. There's a theory called the Hydrodynamic Theory that is responsible for this dentinal hypersensitivity. And it's the new accepted theory that there's movement of dentinal fluid in the tubules that activate the pulp and cause the stimulation. So cold, hot, and pressure stimuli cause the dentinal fluid to start to shift back and forth within the tubule, and that movement excites the nerve. So what do we do? Patients may complain of pain during scaling or when spraying air water with the syringe. So when you're doing your procedure, you just need the pain to go away. So you're going to use anesthetic. If you need to be aware, though, when you're spraying air and water, that if they had root planing on the right quads and they come back a week later to do root planing on the left quads, that those right quads may be sensitive to cold or to the air or to the water. So you want to be cautious when you're rinsing their mouth after you've numbed them up and stuff, because that cold is going to touch those teeth. So just be aware of it. Strategies for management: chemical management, patient education, treating exposed dentin surfaces with lasers, blocking dentinal tubules with restorative materials, and cover exposed dentin with gingival grafts. So patient education, using Sensodyne, that would be chemical management. Also using an ultra soft toothbrush, just not drinking or eating really cold, icy things for a little while. And that's what I would always warn patients too when they're leaving the office. Try to stay away from really icy cold drinks. You might not be able to eat ice cream for a couple of weeks. Kind of warn them of things that try to keep things that are more lukewarm to warm. Treating exposed dentin surfaces with lasers. Lasers are fabulous for treating exposed dentin surfaces. And then blocking dentinal tubules with restorative materials. There are some, you can put composite material. There's also some like fluoride dentin blockers where it's similar to like a sealant. You paint it on the surface and then you light cure it, and it forms a mechanical block between the external environment and the tubules. Or cover exposed dentin with a gingival graft. So if a patient has a lot of recession on their lower incisors, not a lot of attached gingiva, you can kind of kill two birds with one stone by doing a tissue graft where they take tissue from the palate and place it over the exposed root areas. So chemical application, you can do the in-office applications of potassium oxalate or ferric oxalate. You can do fluoride varnishes. You guys have fluoride varnishes in the clinic that you can use to paint on their teeth if they are having extreme sensitivity. Potassium nitrate, strontium chloride, and sodium citrate are found in toothpaste for sensitive teeth. You will need to know those names. Those names will be on a test. Those names will be on boards. So decisions following non-surgical therapy. So now the patient has completed their scaling of root planing. So what do you think is going to happen? You're going to get shrinkage of the soft tissue and a shallow pocket depth. So you'll notice here, in this picture, the tissue is inflamed and swollen. And in picture A, the swelling has gone down, but look what has happened. We now have exposed root surface. So that may give the patient some long-term cold sensitivity. We can have readaptation of the tissues to the root, forming the long junctional epithelium. So in picture B, you can see in all three pictures, the alveolar bone loss is the same. In picture B, the junctional epithelium became longer and thicker compared to where it is in picture A. So it has helped eliminate some of the pocket depth. In picture C, little change in the level of soft tissues resulting in a residual periodontal pocket. So you may not get any change in the soft tissue, and therefore you have a pocket. So here's a picture. Before instrumentation, this pocket has a probing depth of 6 millimeters. After instrumentation and tissue healing, the formation of a long junctional epithelium. This is the same picture that I showed you before. So here's your cementum. Here's your base of your pocket at 5 millimeters. Before instrumentation, the junctional epithelium reattached itself. Now your pocket is only at 2 millimeters, but you've got all this junctional epithelium. Remember the term for the connective tissue plus the junctional epithelium is your biologic width. So now we go to the reevaluation appointment. So we've finished our scaling and root planing. We kind of know what we can expect to see. Now we come to the reeval. So your reeval is your formal step following non-surgical therapy. This is your chance to reassess where the patient is today and compare it with your initial assessment. And then you're going to decide on where to go from here. So the timing of your reevaluation appointment, the tissue healing does not occur immediately. That's why we wait 4 to 6 weeks. For scaling and root planing, we do our first reevaluation at 4 to 6 weeks to kind of see what the initial healing is like. The majority of your initial healing is going to occur in 4 to 6 weeks. However, a patient can continue to have healing for up to a year after scaling and root planing. So 4 to 6 weeks gives us our first baseline measurement of the bulk of the healing. So most of the healing is going to occur in the first 4 to 6 weeks. But remember that they can continue to get healing. The only way they're going to continue to get healing is to have regular periodontal maintenance, meaning at 3-month intervals, and to have good self-care. So at this appointment, this is your time to look at the areas that maybe didn't respond quite as well as others and evaluate, is the patient's oral hygiene and self-care keeping that area clean enough to continue to get healing. If not, we're going to add some things to their home care. So for example, if the patient has a tipped tooth, so they've lost tooth number 30 and tooth number 31 is slightly tipped. So you are going to work with that patient at trying to keep that area clean on the mesial. And so maybe the pocket was a 6 originally, and it's still a 5 today with still a little bleeding. That would tell you that the patient's access to home care is probably not that good in that area. And so you're going to work with the patient on improving their home care to accommodate that different area. So there are steps to your reevaluation. They are basically going to be the same steps that you would do in a perio maintenance, starting with your medical history update and your thorough periodontal clinical assessment. Again, your clinical assessment is extremely important. If you do not do a thorough clinical assessment in the beginning, you're going to not have any baseline to measure your outcome. So if you do a poor clinical assessment and you don't assess mobility, you don't assess frications, you forgot to chart recession, all you did was measure your pocket depths, when the patient returns at their reeval, the only thing you're going to have to compare is pocket depths, which pocket depths alone are not a good assessment of periodontitis. But if you didn't record recession, you might not necessarily know where they were to begin with. So you don't know if that recession went from 2 millimeters to 4 millimeters, or if it already was 4 millimeters and it stayed the same. Then you're going to decide on the next step. So rewind your clock back to the phases of treatment we discussed a few chapters ago. You had your emergency phase or your preliminary phase. Then you had your phase 1, which was your non-surgical. Then we had phase 2, which is surgical. We have phase 3, which is restorative. And we have phase 4, which was maintenance. Hopefully that was just reviewed to you. So we finished phase 1 therapy. Phase 1 therapy includes your initial reevaluation of your scaling and root planing. That is so important you remember that. Your reevaluation is part of phase 1. You're reevaluating your phase 1 therapy, your scaling and root planing. Now we have to decide, does the patient need to go to phase 2, which is surgical, possibly surgical? Does the patient not need surgery and they need to go to phase 3 because they need restorative treatment? Or is the patient just going right on to phase 4, perio maintenance? At this point, your patient should automatically go to perio maintenance regardless of where you're putting them afterward. So let me explain that. You want to put your patient in perio maintenance so that we don't lose track of them. Even if you've referred them to a periodontist because you think that they may need perio surgery, or even if you know they need some crowns or some fillings replaced or a broken tooth or something like that, they need to be in perio maintenance because oftentimes, mainly due to finances, but other circumstances, the patient got referred to the periodontist, but they just never went. They got referred to the periodontist, but the periodontist couldn't get them in for 3 months. Or they need restorative treatment, but they're waiting for their insurance to roll over into next year before they do those crowns. And it's only March. So you don't want them to get lost in the system and not come back. Identification of sites that are non-responsive to treatment. So we're going to look at areas that we're going to do our comparison of our clinical attachment levels, and we're going to look at areas that maybe didn't get as good of a response. You remember the term for not getting a good response to treatment is refractory. You've done treatment, patient's doing good with oral hygiene at home, and you didn't get a good response. That's an overall picture. You're going to probably have areas, though, where you had deeper probing depths that didn't get a lot better. So you're looking at the mouth as a whole, and every place got improvement or showed improvement. There's way less bleeding on probing. It may not be perfect, but less bleeding on probing. Lower plaque, lower calculus. Lots of probing depths went from 5 and 6 to 3 and 4. But you still have a couple of sites. So we want to evaluate those non-responsive sites. First thing you want to do is check and see, is the patient keeping those sites clean? If you go through and their mouth is perfectly clean and everything looks really good, but you have that tipped number 31 because number 30 was extracted, and you see a band of marginal redness, or you see plaque in the area, that would be kind of a red flag to tell you, okay, the patient just isn't getting this area clean enough. So we need to change their home care regimen just a little bit to modify it for that area. Do they have residual subgingival calculus? So oftentimes they've had so much calculus, so tenacious calculus, or from a time standpoint, that some calculus got missed. If there's still calculus at a site, the tissue is not going to reattach itself. The site has to be completely free of calculus for the tissue to reattach itself. Evaluate for other factors that might be contributing, such as smoking. If the patient overall did not get a good result, it could be because they smoke. It could be because they have an undiagnosed medical condition. Now, those are all possibilities. I would start with the more obvious things, though. Do they have good home care? And can they reach and clean all of the areas that are in their mouth? And have I thoroughly removed all of the calculus before I jump into the medical side of it? Establish a program of periodontal maintenance. So 3-month maintenance is the standard. Sometimes patients can go 4 months if they've been stable for quite some time. But you will all the time hear patients say, can I go back to every 6 months because my insurance only pays 2 cleanings a year? The answer would be no. The explanation, as I've said earlier, you might want to explain to the patient about how bacteria builds up, and it is proven that every 90 days, if you disrupt the bacteria, it keeps your periodontal disease in a more stable state. This is just a chart that shows that the process of determining where the patient goes. Indications for surgical therapy. If you remember on your classifications, your 2017 classifications, you have gingivitis, and then you have stage 1, 2, 3, and 4 periodontitis. Gingivitis, no surgery is going to be indicated. Stage 1 or 2, usually no surgery. Stage 3, sometimes. Stage 4, usually. So no, sometimes, usually. Some examples of some suggestions. A patient may have biofilm-induced gingivitis, but they may have enlargement from calcium channel blockers or anti-seizure medications. So the gingival enlargement is going to make plaque control difficult, leading to some plaque-controlled gingivitis. Patient may have 5 to 6 millimeter pockets throughout because of the enlarged tissue. Keep in mind that the junctional epithelium is still at or slightly above the CEJ. Normal, healthy clinical attachments. It's strictly an enlarged gingival margin. In those cases, surgery may be needed. So there are going to be exceptions to every rule. It's not an always or a never. Referring to a periodontist. When do you refer to the periodontist? That's going to vary. Due to the extent or complexity of periodontal disease, referral to a periodontist may be made. Patient may desire to be treated by a specialist. So you're working for a general dentist, you've done scaling and root planing, or you want to do scaling and root planing, maybe the patient might decide they want to see a specialist instead. That's okay. General practitioner may not have the depth of experience to treat advanced cases or desire to treat advanced cases. Advanced cases are very difficult to manage. And so sometimes practitioners don't want to take on that advanced case. The patient is better served if they go to a periodontist. And the presence of complicating medical factors. When you're dealing with a lot of different avenues, say the patient has uncontrolled diabetes, the patient's got a history of strokes, the patient has heart disease, high blood pressure, and periodontitis, that might be a good time to refer them to the periodontist. So risk factors indicating co-managing. In other words, what are the risk factors for co-managing with a periodontist? Unresolved inflammation and continued attachment loss despite non-surgical periodontal therapy. You've done your scaling and root planing. You've done your best job. You've seen the patient back for a re-eval, and they have had very little to no change. That's the time maybe you want to send them off to a periodontist. Stage 2, that should actually say stage 3, or stage 4 periodontitis with severe destruction. So the patient has a lot of destruction. Maybe you've done a scaling or root planing and you've managed the biofilm and you've managed the response, the host response, but the foundation has had a lot of destruction. In other words, a lot of bone loss. Do we maybe want to have a periodontist evaluate for some osseous regenerative surgery? Intensive management of a grade B or grade C periodontitis. So they're at a moderate to rapid rate of advancement. Gingival recession defects that may need to be corrected. Required surgical procedures for tissue augmentation or regeneration. So tissue augmentation or regeneration or rebuilding back bone. Crown lengthening or osseo-integrated implants. Significant medical issues that affect management. And then general practice not comfortable with treating. So if you have your doctor just says this patient I think is too advanced, I want them to see a periodontist. That's the time. And that concludes our discussion about non-surgical periodontal therapy.